Yep.
What do they mean by sporadic concept?
Sporadic, as in, well, usually people use that term to mean that there's no family history. I'm not sure if it was on one of my slides or Dominic's. So I think it was one of my slides originally. So often we sort of talk about, maternal inheritance for mitochondrial DNA mutations that are passed down the family line, but sometimes you get a new mutation in the mitochondrial DNA. So most of the big changes, the deletions, are new mutations. So effectively they're sporadic. There's no family history. They're occurring just in that individual. And the same with some of the autosomal dominant things. You get a new change in a gene and it just appears out of nowhere. In reality, most patients diagnosed with mitochondrial disease these days probably don't have an obvious family history. A lot of them have these autosomal recessive disorders where you have to get a copy from mum and a copy from dad. So unless mum and dad were related, then there's not going to be any family history of that condition. Does that answer your question?
Excuse me, David. How much work are you and the team doing on complex 5?
We haven't been focusing specifically on complex 5, and we've generated some mouse models of mitochondrial complex 1, which is, in children at least, the most common mitochondrial disorder, and which we've done a lot of work in. We've identified a whole bunch of disease genes and so on, so we've made some mouse models there and are trialling different treatment strategies in the mouse models. Our research is improving the diagnosis of complex 5, so we're looking to diagnose them, but we haven't had a focus on it, I'm afraid, just because, again, there are so many things to work on, and our expertise has largely been focused on complex 1 in the treatment sense, because we've developed some good mouse models there. There are some mouse models and so on of complex 5 deficiency that have been generated, and there is work in that area, but it's one of those things. There are so many things we could work on in this area that we haven't had the resources to really focus on complex 5. We put a lot of work, if you like, into the genetic basis, so being able to offer prenatal diagnosis or pre-implantation genetic diagnosis for the mitochondrial DNA versions of complex 5 deficiency.
Excuse me, just on that. What actually, our daughter had complex 4. What deficiency? What does that actually mean? Complex 4 deficiency? Because we went into some really good detail there, which is helping us understand all of this, the deficiency side of things.
Sorry, I'll just. No, that didn't work. Sorry, so complex 4 is one of the complexes, the components of the mitochondrial OXPHOS system, or respiratory chain. So there are two entry points, if you like, for the respiratory chain. We're getting electrons being fed into here to generate energy from breaking down sugars, fats and proteins, and they either come in at complex 1 or complex 2, and they donate electrons to this coenzyme Q or ubiquinone, and that passes electrons through complex 3 to cytochrome C. Cytochrome C is oxidized by complex 4. So complex 4 is it's one of the 5 components of the respiratory chain. It's the one that actually uses the oxygen, and so it's in the latter part of the respiratory chain. So when we're talking about treatments, some of the ones like the high-fat diet are most relevant to where the electrons come in, whereas complex 4 is at the more towards the end of the respiratory chain, and so again some of the sort of genetic bypass therapies are aimed at either bypassing complex 1 or bypassing complex 3 and 4. Complex 4, we measure the enzymes in muscle biopsies and so on. We find they have complex 4 deficiency, for example, and in the past there are some common causes of complex 4 deficiency. One gene, particularly SIRF1, that is the most common one. We've identified 2 more new ones just recently that are being reviewed. So lots of causes.
What's the deficiency? Sorry, what actually is the deficiency mean?
Sorry, what does deficiency mean? So when we get a muscle biopsy, for example, we mush it up, if you like, and look at how well is each of these working. So how well for complex 4 how well can that mitochondrial preparation oxidize cytochrome C, and that tells you how much complex 4 activity there is. So we look at how much, routinely we measure complex 1, 2, 3 and 4 because complex 5 is difficult to assay, at least in frozen muscle biopsies and so on. And so we measure each of them, and if one of them is very low, then it's called complex 4 deficiency, for example. So typically it means in complex 4 deficiency there's a problem, usually not in the proteins themselves but in things that put them together, and if you have a problem there, complex 4 tends to fall apart and is really completely missing, or almost completely missing. Dominic, it's also open for questions
Yes,
here.
Dominic, could I ask you please, I saw on one of your slides pseudo-obstruction of the colon. Would you explain to me the symptoms of that, or what that is? It's not really a bowel obstruction, it's actually a...
No, that's why it's called pseudo-obstruction. So pseudo means not real obstruction in the sense that something's blocking the bowel.
Right.
The bowel may not work properly, propel contents very well because of the fact that in order to do that it needs muscle in its wall. And if the muscle's not working very well, then there's a kind of a propulsive failure. So the consequence of that is that the bowel can seem to be obstructed, but it's not really. It's just not propelling contents very well. And so which part of the bowel? The bowel's very big. There's the mouth and then the anus at the other end. But it's usually in the colon that we see this kind of problem.
Is there any treatment for that apart from is it surgery, or what is normally done?
Sure.
to
So,
correct that?
well, unfortunately, surgery won't really help the fundamental problem, which is in how the bowel actually squeezes the contents. But the person can get into real trouble if the contents don't move through, and sometimes the bowel can blow up.
That's
And
what
it can
we
even,
experience.
it can even, when it blows up, its blood supply can fail. The bowel can become necrotic, it can even burst. So that might require surgery. That's an emergency situation. Now, usually in the clinic, recurrent pseudo-obstruction is not that uncommon in mitochondrial disease. A little bit underestimated, not much talked about. But we do see it in the clinic quite a bit. And if not at the very extreme end of what I was talking about, the bowel actually becoming completely immobile and blowing, at some minor level, quite bad constipation and so forth is quite common in a number of these conditions. So I usually work with a gastroenterologist who's a pediatric gastroenterologist in this area, who works with a lot of other diseases which are similar in children. Like, for example, there's a condition called Hirschsprung's disease, which does have a surgical treatment, where it's not so much the muscle of the bowel, but the nerves controlling the muscle, which are deficient, controlling the wall, which are deficient. So largely it's a matter of symptomatic treatment, adjusting diet, making sure that the person's well hydrated, that they've got diet that doesn't lead them to get attacks of pseudo-obstructions. So it's about diet, exercise, and hydration. But you can't do anything about the fundamental problem.
Yes, this is to get to the emergency surgery stage. And I just
Yes,
wondered if
one
it was
doesn't really
something-
want to see patients in that situation.
No,
So
it's
if
something that could have been
yeah.
done before.
Yeah, so it's about recognizing the problem. So once I recognize it, I usually use a gastroenterologist who often does a colonic biopsy to make sure that there isn't some other additional problem, like, for example, Hirschsprung's disease. And then we make sure there is nothing else. There's no true obstruction, for example, because after all, a patient with mitochondrial disease can suffer all the same disease that everybody else suffers as well. So bowel cancer, for example. So we make sure that nothing like that is the case. And then if a patient does have an attack of obstruction, then that is bad enough to leave them in the hospital. We would not put any food through the gut. We would admit a patient We would give them intravenous fluids, we would rest the gut, we might work at the other end with enemas, short of surgery. Surgery is, of course, the last resort, and that's really to try to salvage a very desperate situation, and we don't usually get into that state.